Thank you for inviting me to speak about subarachnoid hemorrhage. I have no disclosures related to this talk. Subarachnoid hemorrhage is a diagnosis with many potential causes, but the major cause is aneurysmal rupture, about 80 to 85%. The remainder of the non-aneurysmal types of subarachnoid hemorrhage are majority of a specific pattern on CT scan and have a generally benign course. And the remainder are inclusive of the wider differential diagnosis with which you might be familiar. Of these, there are some that are more considered emergent than others, where you can initiate very important decisions in those first several hours. And this includes, of course, aneurysmal rupture, subarachnoid hemorrhage, posterior reversible encephalopathy syndrome, which is related with traditionally hypertension and some other comorbid diseases, intracranial artery dissection, and bleeding diathesis. In those first few hours, you must initiate some important management decisions, traditionally in the emergency room, inclusive of controlling blood pressure, measures to prevent rebleeding, managing and recognizing hydrocephalus and doing this acutely, and reversing any anticoagulation or bleeding diathesis that the patient presents with. I'm going to speak for the remainder of my time about aneurysmal subarachnoid hemorrhage because this does comprise the majority of the subarachnoid hemorrhage patients that you will see. There are two very well accepted guidelines, one being from the American Academy of Neurology, neurological surgeons, neurointerventional surgery, and the American Heart Association, and the other one being from the European Stroke Organization, and I will refer to these in the rest of my talk as the American and the European guidelines. Aneurysmal rupture, while not representing the most common type of stroke, is very important because of the types of people that they tend to occur in. These patients tend to be in the peak of life in relatively young age compared to the other types of common strokes. And because of this, in survivors, results in significant lifelong accumulated morbidity in the survivors. A significant number do die before reaching the hospital, but this number seems to be decreasing over the decades. And of those who survive, about 10% die in the first few days within the hospital stay. Presentation should be familiar. Most commonly, this is the worst headache of life associated with nausea or vomiting, sometimes with loss of consciousness. You can see focal neurological symptoms or even more of a general altered consciousness. Frequently, you'll hear in conscious patients a complaint of nuchal rigidity, and you might be able to elicit a history of a sentinel headache or a headache that's unusual for a patient's history in the preceding interval days prior to the major rupture. While it's unusual, it does not rule out seizure if subarachnoid hemorrhage if a patient has had a seizure. And contrary to popular belief, the non-exertional types of activities are actually more frequent in report prior to the rupture of an aneurysm, and lateralizing signs can be present even in the setting of a subarachnoid hemorrhage. So what leads to misdiagnosis? Is typically the failure to appreciate that this clinical presentation can have quite a wide spectrum, and then is the failure to obtain to either obtain a head CT or to perform an LP, and if those are done, is the failure to understand the limitations of the CT scan based on timing or incorrectly interpreting results of the LP or the lumbar puncture. So when a patient presents with a subarachnoid hemorrhage, the most straightforward pathway is to go from your symptom presentation, obtaining a head CT without contrast, seeing the subarachnoid hemorrhage, getting either a CT angiography or cerebral angiography, and then finding the aneurysm. That's pretty straightforward. Patient is admitted. They await very prompt treatment for securing the aneurysm, end of story, and the treatment is in the intensive care unit. A little bit more complicated is if with the typical presentation where you suspect subarachnoid hemorrhage, the CT scan does not show a subarachnoid hemorrhage. At that point, you must do a lumbar puncture. If it's completely normal after 4 tubes, you can stop in the workup. But if it's abnormal, you must get a CT angiogram. So it's this arm or this arm. If it's unequivocally abnormal, meaning it's very highly suspicious of a subarachnoid hemorrhage, after getting the CT angiography or cerebral angiography to look for an aneurysm, even if that is not found, that patient should be admitted and either repeating the angiography in a week or CT angiography and considering an imaging of the spine or the brainstem. If it's equivocally abnormal, meaning it's abnormal in that there might be a slightly elevated red blood cell count, but you don't see xanthochromia, or you've only been able to analyze one tube without looking at the fourth tube, you could do a CT angiography or cerebral angiography to confirm to yourself that this patient does not have an aneurysmal subarachnoid hemorrhage. And if it's normal, you can stop. And if it's found, then you can treat. And why is it important to understand? So CT, if it's done in the right time frame, meaning within 12 hours of headache onset, nearly 100% of subarachnoid hemorrhages will be identified. But in a delayed fashion, or with very small or atypically located subarachnoid hemorrhage, a subarachnoid hemorrhage can be missed with a CT scan. And in a lumbar puncture, when we use it to rule out, it must be unequivocally absolutely normal, meaning by tube forward, there must be no red blood cells. You can use this to successfully exclude subarachnoid hemorrhage. If the LP is performed about at least 2 to 6 hours after the onset of symptoms, you can check for the xanthochromia to raise your suspicions for subarachnoid hemorrhage, to then go for a CT angiogram. 12% of these patients are misdiagnosed. And this, if the patient presents without any symptoms, this misdiagnosis goes up to 20%. This is important because these misdiagnosed patients who present with a normal mental status with the opportunity for diagnosis result in a fourfold increase in mortality at 12 months, and certainly increase morbidity in those who survive. So we're going to go into a little bit about the management of subarachnoid hemorrhage in the subacute, still acute phase in the intensive care unit. Patients with ruptured aneurysms must be monitored at least every hour with an eye towards avoiding increased ICP, looking for abnormalities in cardiac telemetry, and keeping the patient normothermic and euvolemic. Blood pressure goals are slightly different from the American and the European guidelines, less than 160 for the Americans, less than 180 for the Europeans, but certainly they agree on avoiding rebleeding by maintaining a controlled blood pressure, while on the opposite side, maintaining cerebral perfusion pressure. In higher grade, more severe subarachnoid hemorrhage patients, intracranial pressure can be elevated, and these patients may not tolerate even transient hypotension, which can lead to ischemia. A very important thing in the acute period is to avoid rebleeding or try to prevent this. And this is trying not to disrupt that transmural pressure, having too many changes to disrupt that fibrin clot, which is keeping that aneurysm from worsening at the moment until it can be occluded. Control blood pressure, avoid any kind of straining, looking towards bowel movement management, inserting a Foley. If a patient comes in anticoagulated, there are very clear guidelines to first discontinue anticoagulation and antiplatelet use. And if there are no symptomatic or life-threatening thromboses to consider, urgent reversal of the anticoagulation. The antiplatelet reversal, the evidence is not quite as strong, but if neurosurgery is planned to occlude that aneurysm, then certainly platelets are recommended. And so for most cases, patients on antiplatelet do receive platelet transfusions, and you can consider a dose of DD-AVP. There's a role for antifibrinolytic drugs, including tranexamic acid and aminocaproic acid, if there's an unavoidable delay in the aneurysm securing, and if there are no compelling medical contraindications. And while this reduces the risk of early rebleeding, there is no great evidence that it improves outcome yet. When you're considering tracheal intubation for patients with high-grade subarachnoid hemorrhage that meet the criteria, the major points you want to consider are blunting that hypertensive response, again, to avoid rebleeding by disrupting that or changing that transmural pressure across the fibrin clot, and really judging the tolerance that this patient is going to have for even transient hypotension. So higher grade subarachnoid patients with perhaps a focal or a general decrease in mental status, you might suspect they might have increased ICP or intracranial pressure. Hydrocephalus, once it's recognized on CT scan, must be treated. If there's blood in the third or fourth ventricle, place an external ventricular drain. But if the pathway is clear, but the patient has symptomatic hydrocephalus, or if the patient is sedated and you don't know if the patient is symptomatic, this warrants a lumbar puncture. Again, consider early transfer. If your hospital treats less than 10 cases a year, patients can benefit from a more high volume center where they can be exposed to more experienced neurosurgeons and endovascular specialists and the multidisciplinary neurointensive care services when that's available. Anti-epileptics are also slightly different in their recommendations for prophylaxis. The Americans say that it could be considered in the immediate post-bleed period, and the Europeans say there's really no evidence for prophylactic use. However, if a patient has clinically apparent seizures, especially in the ruptured aneurysm period before it's secured, you should consider anti-epileptics. But if you do use it as prophylaxis, it is recommended to discontinue it at 7 days unless the patient has real risk factors such as prior seizures, continuing seizures, perhaps an intracranial hemorrhage or an MCA aneurysm in particular because of the location. Early brain injury is that period of first 72 hours after injury. And while this is an area of high study, it's clear that this is very important, separate from the period of vasospasm. Vasospasm is the focal or diffuse narrowing that occurs about 4 to 14 days after subarachnoid hemorrhage. And you can induce hypertension per the American guidelines, but no evidence for this in the European guidelines. But we monitor for this with transcranial Dopplers, perfusion imaging, and it can be treated with angioplasty or vasodilator therapy through intraarterial means. Delayed cerebral ischemia is that deterioration that occurs after subarachnoid hemorrhage and is represented by a very specific worsening neurologically that's not explained by any metabolic or fever, seizure, or other cause. And this leads to the highest risk for morbidity after subarachnoid hemorrhage. The best proven therapy for subarachnoid hemorrhage to improve morbidity and outcome is nimodipine. And so whenever possible, oral or enteral nimodipine should be given. And even in the cases of hypotension, you should endeavor to try to continue nimodipine by reducing the dose and increasing the frequency. And even some patients who are on pressors may still receive nimodipine. This is a gray area about the threshold when to hold nimodipine. So in summary, this very short, high-level view of subarachnoid hemorrhage, I hope that you take away from it that a negative CT and a negative LP cannot rule out, can rule out in acute presentation a subarachnoid hemorrhage, but you must understand the nuances when obtaining a CT that's delayed or in LPs that are improperly interpreted. When in doubt, get vessel imaging. And recognize that there are several presentations of subarachnoid hemorrhage where you can do something acutely to improve the morbidity of that patient. And primarily this involves controlling blood pressure and preventing rebleeding while maintaining cerebral perfusion pressure. When there's hydrocephalus, do something about it. Patients can improve very rapidly. Transfer to a high volume center if you treat less than 10 and watch for that period of the first 3 days of early brain injury. Monitor for vasospasm, and recognize delayed cerebral ischemia by ruling out mimics. And absolutely, when you can, give enteral nimodipine. Thank you for this opportunity to speak about subarachnoid hemorrhage, and I hope you enjoy the rest of the conference.